Hi, I'm Dr. Vidushi from SuVi Eye Hospital, Kota, Rajasthan, India, and in this video we discuss the management of infantile cataracts. The key issues in these cases are the timing of surgery, which IOL to implant and whether or not to implant the IOL, the surgical techniques, and most important, the post-op follow-up. Team effort is important with the anesthetist and optometrist involved. Management of anterior and posterior capsules may pose special challenges depending on the age of the child. The usual guidelines followed for IOL power calculation are in less than 2 years of age, 80% of the calculated IOL power is implanted, in 2 to 8 years, 90%, and above 8 years, a full IOL correction is given. A good examination before planning surgery is extremely crucial, and this may necessitate examination under anesthesia for these small children. Some children may allow examination without anesthesia if they are cooperative, and we should try to extract the maximum information in these examinations. EUA is often necessary for IOL power calculation as well as for other examinations of the eye. Fundus examination should always be performed as they may have other problems, and indirect ophthalmoscopy may be more useful in these small children to see if there are any other associated eye problems. Along with that, we always check the intraocular pressure using a Schiot's or a handheld applanation tonometer. For the IOL power calculation, a handheld keratometer is necessary for these small children. Cooperative children may allow handheld keratometry to be performed without anesthesia, but some of these children may not be that cooperative and keratometry may be performed under EUA. An A-scan measurement is done for the axial length, and then the IOL power is calculated and the intended power according to the age is found out. In surgery, the management of capsule is very important. We use the ultimate soft shell technique for capsule staining because the capsular excess can be very difficult in these small elastic capsules. So here we are first injecting Helon 5 into the anterior chamber, and beneath the Helon 5 we inject a pocket of BSS which is then stained with the trypan blue dye. The dye is then washed out after an interval of about 10 seconds. We then initiate a capsular excess with a 26 gauge needle and then use a capsular excess forceps. The rexus has to be performed in a very controlled fashion as these capsules are fairly elastic and fragile, and extension of the capsular excess can easily happen. It is important to pull the capsule in a centripetal manner and to re-grasp the capsule again and again so that we intend to perform a small rexus. However, it ends up becoming larger than intended. So always follow a centripetal motion and re-grasp the capsule often. Because these cataracts are very soft in these small children, they can usually be aspirated using irrigation aspiration. In children, a single-piece hydrophobic acrylic IOL is preferred because of the greater biocompatibility of the material, as well as the single-piece configuration that allows implantation into the small capsular bag of these children. And the hydrophobic acrylic IOL also has the least degree of posterior capsular opacification in the postoperative period. It is crucial to remove all the viscoelastic from the capsular bag and fornices, and especially from under the IOL, as we have used dense and viscous viscoelastics like Helon 5. Anterior chamber maintainer is a good idea in these small children because of low scleral rigidity. It maintains the anterior chamber very well. Now, the incisions in small children should preferably be sutured because the low scleral rigidity causes fish mouthing of the incisions in the postoperative period, and the children tend to rub their eyes, which may also cause problems with the healing of these incisions. Intracameral preservative-free triamcinolone is then injected into the anterior chamber, which allows any vitreous strands in the anterior chamber to be easily visualized, which can then be removed using the irrigation aspiration or the vitrectomy cannula. And we can ensure a clear anterior chamber and visual access at the end of the surgery. The intracameral triamcinolone also has some help in the postoperative anti-inflammatory action, as it may be difficult to put frequent eye drops in these little children. This is another clip showing the injection of intracameral preservative-free triamcinolone into the anterior chamber. Fluorescein is used to see that the incisions are well sealed. The triamcinolone is then washed out, and any vitreous strands that may be present in the anterior chamber are clearly delineated with the triamcinolone. Postoperative follow-up and postoperative EUAs are extremely important in these children to follow up for any complications and for the postoperative refraction. This is a child showing clear visual access at 8 weeks. Many of these children may have anterior and posterior capsular plaques, and their management can pose special challenges. Here we see an anterior capsular plaque, and it is dense and extremely adherent, and it is extremely difficult to remove it. We are attempting to remove it performing a capsulorhexis. The anterior chamber maintainer helps in maintaining the anterior chamber during the procedure. As you can see, it is extremely difficult and tenacious anterior capsular plaque which is removed with a lot of difficulty. And here we have the anterior capsular plaque that has been removed using a capsulorhexis forceps. Despite the dense capsular plaque, the cataract as expected is fairly soft in the child and can be easily removed using irrigation aspiration. Posterior capsulorhexis is performed in children below 8 years of age, and below 5 years of age an anterior vitrectomy is also done to reduce the incidence of posterior capsular opacification. Here we can see a posterior capsulorhexis that has been performed using a vitrectomy and the anterior capsulorhexis which is much larger. Again, intracameral preservative-free triamcinolone is being injected into the anterior chamber to stain any vitreous strands, and here no vitreous strands are seen in the anterior capsule after washing out the triamcinolone. Some of these cases can also have a similar dense plaque in the posterior capsule. Sometimes there may also be a pre-existent dehiscence of the posterior capsule which may need to be managed appropriately. As seen in this case, the cataract is fairly soft, removed with irrigation aspiration, and now this is the posterior capsule plaque that we have to deal with. A careful plaque peeling is being performed. It goes without saying that these movements have to be very controlled and careful so that we do not stretch the posterior capsule or the zonules too much. And with the help of a lot of generous viscoelastic, the plaque has been peeled, as you can see here. Here, anterior vitrectomy is being performed after implantation of the IOL, and in small children below the age of 5 years, this is important to do. Especially after an anterior vitrectomy, it is extremely important to inject intracameral triamcinolone into the anterior chamber and carefully remove any vitreous that may be present. So to summarize, management of infantile cataracts is a team effort and needs special efforts on part of the ophthalmologist and the entire team. Management of anterior and posterior capsule is important depending on the age of the child, and we recommend this textbook on pediatric cataract surgery for this purpose. Thank you.